Mel. Hi, everyone. Welcome back to the Queer See Me podcast. We are still here despite everything that is happening in the country. And I'm very excited to have, do you go by Lindy actually?
Mel.
Go by Mel. Okay.
Yeah. Lindy's my childhood name. I love it. I use it for my music stuff more so than my professional stuff at this point. So.
Okay. Well, I'm very happy to have Mel on today. Who, gosh, we first got connected years ago. I think when you were considering virtual gender care in New Mexico or Arizona.
Yep. I'm physically in New Mexico. Yeah, in the high desert, in a quirky little art hot spring town now. But during the pandemic, the first Trump term.
Yes. Oh my God, we've been circling each other for a long time. And then you opened More Spoons Nutrition, which I have been very excited about. I sadly want you to be open in more states, just because we offer services in 10 states, and I just think so many of my patients, I feel would love to work with someone doing the work you're doing. And so I'm just really, really excited for you to tell us more about who you are and the work you're doing, so other clinicians can know about this resource. Because I think I get asked, so many questions in particular about what food should I be eating during my medical transition, and how can I help with my weight redistribution and all these kinds of things, which there isn't a lot of science or data behind, but even to have someone who has some knowledge of the community and knowledge of the nutrition to go to feels like such resource gold, to me. So I'm very excited to hear all about you. Why don't you tell, as I'm running along on my monologue, why don't you tell our listeners who you are?
That was such a lovely monologue. Just before it goes out of my head, just to speak to, the data around trans health and nutrition is so sparse. It's kind of ridiculous. And the studies that we have are maybe just over a decade or so old at this point. We really don't have much data to go by. And so, I think my perspective, coming from also having a PA license and having worked in the hormone therapy world and then coming in with nutrition, gives me a little bit more of an ability to maybe blend those two. So that was a little aside. I guess I should introduce myself a little bit.
That was some of your introduction anyway. So you're I am a PA and a nutrition specialist, both of these things combined.
Yeah. At my practice, I do not practice as a PA because that would mean that I have to hire a supervising physician. Nutrition does not pay that great comparatively. So financially starting out, I'm using my RD license. Not that anybody needs to know the background info on the back end, but don't send me anybody that you need a PA for, please. Because it'll just be under my dietitian license. So I got my dietitian license in 2012, and I did my internship entirely with tribal populations in Arizona. So my background is primarily working with tribal populations, marginalized groups, lots of poverty. And so I think I bring that up because I think that really applies to also how I practice nutrition. Oftentimes we think of nutrition as this very out of reach thing that people can't access, but I think I want to start with, everybody can make changes if that's what they want to make. Obviously, there's a lot of different ways to health and wellness, right? But I don't want that to be a barrier for people or for them to feel like they can't access those types of services just because food is just a problem to even have as a resource, right? Most of the people I've worked with over my career don't have access to buying food at Whole Foods, buying all organic, and I think we get this really specific idea of what healthy eating is.
Definitely white people do. Which, if you're not watching, I am definitely white. I don't know Mel's origin, but we're both definitely white, perceived and white passing.
Yes.
And I do think in our community, particularly with like people with higher education levels and stuff, there is a very specific connotation to healthy eating. And I love that you're bringing to this conversation that like, even in that one, that's not the only answer to like nutrition. And to that, like, in spite of the fact that there are systemic forces of oppression affecting people's access to food, right? And like, gosh, I like didn't prep at all for this. I'm like just like food sovereignty is like huge, right? And it's a huge part of like resistance to everything that is happening in capitalism and in Western culture right now. And even within all of those oppressive structures, there are still ways to find health and wellness, even without some of like the access that we think about in like specifically like white educated spaces. And I do think like, I love that you bring in your work with Indigenous community, because like it also like leads to the point that like food is culture and food is community. Right. And it's not, I think that's something, again, we lose in white supremacy culture so fast. So I love that you're bringing that in. Before we like run into those topics though, like you are Mel, you're a PA, but your work right now is really focused under your dietetics license, and you're working in the nutrition space. But also, will you share just like how you identify as a human? And then we'll go back to the food.
Yeah, that's where I meant to go. Sorry. Just all the ideas. So yeah, I go by Mel. I identify as non-binary, autistic and disabled. And those are, you know, autistic as a political identity. I also have a diagnosis. My disability comes and goes. I have mast cell activation syndrome myself. And so there's like this waxing waning piece, as well as like various levels of autistic burnout that come and go in my life. Non-binary in like, definitely autism influences my experience of gender. And so I can't negate that. I think I would probably be more consistently femme if it wasn't such a sensory problem. Like this dress, I love, it's bamboo, like, but it's, you know, and I love like going into the vintage stores. I have a collection of vintage dresses I cannot wear for the life of me. They're just hanging out, being a collection.
We love collections. And do you mind sharing? I have found this like, I've been, watching some cultural conversation and been having these conversations myself around like, does claiming trans as a label or non-binary as label as people who like maybe haven't medically transitioned, does that erase the experience of people who have? And I think, we don't have time for that whole conversation today, and that's not what I'm asking us to do. But I have been, I try to be like fairly discreet when I'm teaching and training and in my materials to like be clear that like medical transition is not part of my story, that like I live deeply in community with people whose story it is, and that really influences my work, but that like it's not something I have personally lived the experience of. And so I if you feel comfortable going into those details, I feel like it's a lovely time to share that. And if not, we do not have to.
Yeah, totally. I think it's super pertinent as well to the work that I do and like why I do it. I did my undergrad in San Francisco, so like, I've had a lot of exposures, a lot of community around activism and queer community and trans community. I have not transitioned myself. It's not something that I anticipate I'm going to want either. I don't have gender dysphoria. My spouse has transitioned. They are also non-binary and have gone through that experience. And so I have like very close connection in that way to the community as well. And of course, serving the community as a PA, that's where my work more with the community came in as far as medicine comes into the picture as a PA. And from the time that I started, right, 2017 until present day, I'm still doing hormone therapy for the community as a PA. Yeah, so that's my journey.
Thank you so much for sharing. I do. Yeah, it's been an interesting conversation because it's come up some on TikTok, and I'm like, well, there's a time limit on my TikTok videos and how much I can say, and I don't feel like I need to like give everyone the laundry list. But I think when we have a longer framework, it's nice for people to understand where we're coming from.
Yeah,
I think
find your TikTok.
God. So, anyways, thank you so much for sharing. Okay, so let's really talk about like how your like what your nutrition work is and how it intersects with trans healthcare. I would love to hear about that.
I think first and foremost, creating a space that's comfortable for people, creating a safe space. My spouse that I mentioned is my front office right now. Yeah. So you will be received by, you know, another member of the family. That's usually how I introduce myself to my patients as well. Like, hey, we're family. Like, so we're already in that space of making sure we're checking pronouns and trying to be respectful of other identities in our practice. I'm getting a little bit of like an echo thing going on.
Oh, I can mute myself.
Oh, is that what's going on? Okay. Oh, that's very quiet now. So what did I want to say about that? So I think centering autonomy and consent, just as we would with hormone therapy, it's hugely important with nutrition. I think even to 10 times the degree, because we all have to eat, and it's something that's happening on a consistent basis every day. If you're doing your hormone shot, maybe it's once a week. Like, you don't have to think about it as much. But food, you're gonna have me up in your business. So I want to make sure that it's not me calling the shots as far as anybody's diet is concerned or what they're putting in their bodies. And I'm just there to provide the information and whatever type of support somebody needs. Also, supporting neurodivergent folks who are also trans, like understanding the sensory differences that I experience myself, but being respectful of those differences as well. And understanding that I'm working with a group of people who are highly marginalized, right? And so that comes with a whole slew of things, which you're very in the know about, right? But also, and we know what we do have in the research is that trans folks do seem to disproportionately experience disordered eating behaviors. And so especially being sensitive to that, and that I think brings us into, using healthy at every size and that framework as well in working with trans, neurodivergent, and marginalized folks, and how important that is. And, not making anything about weight or body size or restriction. Yeah.
Yeah, I feel like I have a statistic in my brain, but I can't remember the source material. And so I don't know how accurately I'm remembering the statistic, but I feel like one of the trainings I went to maybe at WPATH in 2019 was about disordered eating in trans patients. And I feel like it was something like it occurs at 4 times the rate of our cis peers.
That was there was a college student study. So it was a really, really small sample size, but they did see that in the data.
Yeah. And so just again, because our listeners are mostly, hormone prescribers and other clinicians. And so one of the things I do in my pre-visit paperwork when someone's doing an intake for gender affirming care with me is we do ask specifically about disordered eating, right? Like we ask a screening question about if they have any, I can't quite remember how I've had the question phrased, but yeah, if they have
that's a great idea.
any concern for any disordered eating themselves. And then particularly with my adolescents, sometimes they don't have like disordered eating in the context of like body dysmorphia or binge or purge and restriction patterns, but they have so many sensory issues with food, right? And so like the sensory component of like nutrition and food intake becomes like a big one. And I know specifically on your website, you talk about working with folks with sensory issues with food and disordered eating and RFID, which I see really commonly in trans adolescents.
That's a lot of the group that I'm serving in that regard. Absolutely.
Yeah. And then also so commonly in our trans patients, right, we do have like connective tissue disorders and hypermobility, POTS, and MCAS, which I feel like
the cluster.
So just tell us a little bit more about how, obviously you're doing a lot to create a trauma-informed and affirming and inclusive space for folks.
Yes, those are the words I was reaching for, trauma-informed.
But I would love, to hear, for our clinicians, to hear a little bit about like how you approach the actual like nutrition, like working through the nutrition with people, just so they get a sense of like what they would be sending patients to do from a interventional standpoint, I guess maybe is what I'm trying to get at.
Yeah, exactly. That makes sense. So like you just brought up the cluster, which I think is super important. And that is a huge part of what I focus on as well, because there's so many intersections there with the trans and non-binary community and neurodivergent community. It seems like we're disproportionately affected by these things like mast cell and POTS and EDS. And it's so important in that setting to use HAES, I would say, healthy at every size perspectives and trauma-informed care, because a lot of these folks are, for one, having difficulty even engaging with nutrition because perhaps they've gone into doctors their entire lives and been told that their body isn't right, when this oppressive anti-Black, anti-fat type of perspective that is so pervasive in medicine. And so even engaging with nutrition can be really difficult for people getting in to see me. I think for providers, it's really important to know that, and when you're starting to send people over to a dietitian, I would ask they please do not call their patients fat and tell them they need to lose weight before they send them to me, because nutrition is so much more than that. I even put up my big book. All of this, you can do all of this. Like everything you could possibly learn in medicine, you could send them to a dietitian for. Oh no, you're muted.
Thank you. Sorry. I feel like that book could be used as a weapon. It's huge.
It's massive. I think I've used this for like some Pilates exercises at some point.
Amazing. Much better than a weapon analogy. We appreciate the change in tone there. And absolutely, I love, I love that you tied, right, like fat phobia to racism and anti-Blackness, right? And I feel like if any of our listeners haven't looked at, it's Sabrina Stream's work, right?
The Body Is Not an Apology. Is that Sabrina? Or that's Sonia?
Yeah, Fearing the Black Body, I think, is Sabrina's work. And maybe yes, Sabrina has more, but that book is very about like the racial origins of fat phobia, which I think is phenomenal. And then there was another really good book about it recently, but I can't remember it right now.
I think have you read Decolonizing Wellness? Who's the author on that? I have it written down.
Oh no, but like, should we put it? We'll put all of these on under for people. I'll put the links up for all of these for people.
That's by Dalai Knisey, and she, I'm not sure what their pronouns are. She maybe are a dietitian as well. So it's from a dietitian perspective.
Amazing. But yeah, thank you for linking that for our listeners in case they haven't been exposed to that concept before. I think that's getting like more into the culture of healthcare providers, but always still, we never know. Okay. And so, okay, we were talking about.
Yeah, I went off on a little tangent.
Yeah, back to like what the, yes. So very clearly though, I will point out to our clinicians, to our listeners that Mel said, you know, do not call your patients fat and tell them that they need to lose weight before you send them to the dietitian. Or and I think that comes in the greater framing, like that there's, in what you were doing when you were showing your book, is like there are so many reasons to consider working with a nutritionist or a dietitian that are not about weight, right? Or not about weight loss. And frankly, one of the like most common issues I run into with trans patients specifically is like a need for weight gain. I have some patients, you know, who just like a lot of the sensory or RFID stuff that were really right, and they want to have like a curvier body, and I'm like, we need calories to get curvier. Like we need more energetic content in your body. But yeah, there's all these other, as we were saying, like MCAS, hypermobility, sensory issues, and POTS, like can all benefit from working with someone with like advanced knowledge and how nutrition can support each of these. So I would love if you would tell us a little bit more about that advanced knowledge, like high level summary for the referring clinicians who do not have dietetics degrees.
Yeah, I forgot to like even describe the difference between like dietitian and nutritionist. That would probably be helpful too, because I think we trained with doctors in our internships, but I swear I come across people that don't seem to realize that we're actually licensed healthcare professionals. So dietitian, you have to have a degree, at least a bachelor's. Now it's a master's before you can sit for the dietetics board exam. And on top of that, at least 1,000 hours of internship that includes outpatient, inpatient, some community health, some food service, because we have pretty diverse settings that dietitians can work in, and we do work in hospitals and nursing homes, all that. So we're trained to help with TPN, all the way to let me just be here to support you in creating healthy lifestyle changes. Working with diabetes, I think, is pretty commonly associated with dietitians, but we do kind of everything. And yeah, there's nothing that dietitians can't really work with, I would say. Everything can benefit from some level of nutrition care, I would say, in the medical setting. But as far as how would I approach, you know, nutrition in our trans folks, and especially with complex chronic diseases, I think that the important piece going into this is really realizing that there's this really fine line you have to walk when you're talking about complex chronic disease, and what you're going to do measures wise as far as diet changes. Something like mast cell activation syndrome, what I have, it is incredibly complex to really put into action for people. Yes, you can give them a handout that says, please avoid these foods. I wouldn't really recommend doing that. It's incredibly overwhelming. For a patient who is neurodivergent, you just handed them a list of foods that maybe has all of their safe foods on it that they can no longer eat.
I've been laughing. I love that you called that out. I'm just laughing over here because yeah, my like vegetarian, not chicken nuggets that I eat, like,
oh, I love
that. Right, like my safe food. And safe foods are a big thing in my life, but I feel like that one is like a recurring one for a lot of people.
Yeah, that one is incredibly common, the non-chicken nugget, even for people who eat meat. The vegan chicken nuggets, which unfortunately is no longer safe if you have mast cell activation, and you can't really have any processed foods. When my spouse and I both have mast cell, and when we went through the transition to the diet, which was 100% worth it. We had meltdowns for weeks, like adult meltdowns. Like there's just, you look in your fridge and you're like, I have no idea. I do not have the level of executive function to put together a meal right now. And it has to be fresh. Like, are you kidding me?
The amount of like knowledge it takes to like even meal plan, meal prep, and then is like so much. And then when you're adding like these, and potentially you've learned that in your community, in your culture, and then suddenly, particularly, right, your white healthcare provider is like, here, don't have these 27 foods that are like a part of your cultural identity.
Yeah.
It's so complicated.
Yeah, I appreciate that you bring up the cultural piece too, because yeah, anything, and I think especially the benefit of dietitians is that I would say the majority of us have at least some training in working with cultures that are not our own, to, you know, various levels, versus like sending them off to a nutrition coach of some kind, you know, that might not have had those experiences. Most of us do at least a rotation with WIC, you know, or something of that sort. And in my experience, you know, working with tribal populations, I worked with the Gila River Indian community south of Phoenix for several years and worked on projects to make sure that providers also had handouts that were culturally appropriate. And so that is obviously huge. We don't want to be handing anybody a list of foods that are not part of their culture. That's absurd. Why would you do that to someone? Like, you wouldn't like that.
Absolutely. Yeah. So I think there's just like, yeah, I mean, food is so intrinsically linked to our experience of like humanness and also of our health and our health conditions, and of our identities and our communities, that it's like, I guess I'm saying all of this out loud because like, one, I think about this concept sometimes, but not necessarily a lot or often or regularly. And I think as a prescribing clinician, it's really important. Like, and it's hard, right? Because like people sometimes don't have the access to a dietitian or the funding for. Oh no, are you you're frozen? Can you still hear me?
Yeah, I can hear you.
But like how beneficial it can be when we can get someone to work with someone like you, because I don't have the training and the skill and the knowledge that is needed to like help support people in this way. And I think so often patients want me to.
Yeah.
Right. They want me to know this and they want me to have advice for them. But like the advice I have is very like it has limited science behind it. And it's mostly like rooted in my own bias and lived experience. And so it's really important to have people like you in my like referral back pocket, right, to help support my patients with this.
Yeah, well, and I 100% understand from the provider's perspective as well, how even having the knowledge, it's impossible, I would say, even having the knowledge to really do what I do in my practice when I'm practicing in my primary care practice that I work at, because there's just not time. And I do an 1.5-hour intake with people that's usually covered by insurance to do the 1.5 hours, the first visit. And we go deep. Like, I want to know everything about where somebody's coming from. I like to get their medical records. I look over that. I look over the labs, look over their medical history. We talk about poop a lot. Like, that's a big topic. Lots of poop. You know, look at the Bristol stool chart together, go over supplements and meds. But I think, especially speaking to the cultural piece, I want to know who's in your household. I want to know what you're usually eating. I want to know what your barriers are to eating, before I make any advice come out of my mouth. You know, I'm not going to tell somebody something that isn't appropriate to what their lifestyle is already set to do, because it's not going to happen. It's not going to be realistic for somebody. If I'm putting that together in a way that's understandable, I hope. But so I definitely take a big perspective.
Yeah. And I think that perspective is so important in all of healthcare. But yes, it's like the importance of that is amplified when we're talking about something so woven into our daily lives as food and meals.
Yeah.
I do. It's one of my biggest pet peeves when clinicians make impossible recommendations to follow.
Or like tell you to do the fad diet that they're currently doing. That's my big one. Like,
no, that's a big one. I feel like, you know, when my physical therapist is like, do this 10 times a day, I'm like, what? Like that's like impossible. Like this is a stupid place. And then I feel like, yeah, prescribing clinicians, even outside of things like nutrition or physical therapy, I see like so commonly bring like prescription medications to the table that like they have no idea how the patient is going to access, like cost wise, insurance wise. Like this happened to me with my Ajovi for my migraines. The neurologist had no idea how to help me afford that medication. And let me be clear, I'm a Kaiser patient. It's an HMO. It's a closed plan system. It's not like this neurologist doesn't know how like the 42 different plans in my state function. They don't know how we have one pharmacy, like the Kaiser specialty pharmacy.
Yeah.
And it was so just to make it about me for a minute, it was so bizarre, right? Because there is like the prescription was like, I think my copay was still $400 and something once like insurance covered it. And there's these copay assistance cards, right, that you can get when you have insurance. But within the Kaiser system, the only pharmacist who can do a copay assistance card is like the specialty pharmacist. But like no one told me that. So like I talked to my neurologist, I talked to the pharmacist at like the regular walk-in pharmacy. I called like the plan benefit like manager people. Like I talked to like 4 or 5 different people trying to figure out how to make this copay assistance card work, and like no one could help me.
That is so frustrating.
I know. And I guess I had also sent like a message somewhere as well. And 3 months later, I got a call from the specialty pharmacist and was like, hey, we heard you needed assistance with this. And I was like, well, yeah, like 3 months ago, I've been paying this copay. And they were like, oh yeah, everyone should have sent you to us. Like we're the only ones who could do it. And I'm like, no one sent me to you. And then they put it in, and then I pay $15 for 90 days of medication now instead of $400 for 30.
Wow.
I was like, I hate everyone.
Well, and you're somebody who understands the system, trying to navigate it.
Right.
Mm-hmm.
And so I just a point, like I've derailed Mel's talk about dietetics and nutrition, but I think what I'm trying to say is like that point of like really understanding my client or patient's like resources and then understanding from them what is possible to affect or impact and change is such an important part of healthcare that we weren't really taught in medical school. Right? We were taught like this condition, this drug, these signs and symptoms, this workup. We weren't taught a lot about how to navigate resources of our healthcare system. I know it can feel really frustrating for clinicians, but I think it's such an important part of the work that we do. I wrote a step-by-step handout for my neurologist to give to the rest of her patients.
That's wonderful.
But I love that you're taking such a like you're taking that and using it in your assessment approach in order to like set you and your clients up for more success, which I think is really important and impactful.
Yeah. And I know there are doctors out there that do spend more time on nutrition. It's not to negate their efforts at all. I just know how hard it is for me, even having the knowledge, to work in our capitalist medical system and actually have time to get into any kind of real discussion where I'm not just blurting out, really random things. I think the one tiny thing that I will say to people, if I only have a few minutes, is we want to have about 30 different plants in our diet a week. And that includes your tea and your coffee and your spices.
I don't think I'm anywhere close to that.
And if you can encourage people to get closer to that, that's going to promote good microbiome diversity. And of course, we're going to get more veggies and fruits in there. But, you know, beans, your chicken nuggets count. That's a plant, right? At some point.
Me realizing I need to come see Mel for my own nutrition consult. But yeah, I think it sounds like really impactful, like large picture intake, and then really working with your individual clients to like modify and adjust, like kind of iteratively, I'm going to guess is what you do.
And sometimes very slowly, especially with neurodivergent and complex chronic disease. I mean, people only have so many spoons, right, when they're dealing with those conditions. And so it's like really tiny pieces. Once we get the whole intake, if somebody can go through it with me, and then we're just following up pretty frequently, usually at least monthly, say, okay, how's it going? Where can we like tweak this? Even if somebody has like SIBO or like small intestine bacterial overgrowth or mast cell activation, you know, tends to backfire working with this population if I just go, here, have fun with this information, like, or subtracting anything even. Like the more we can focus on adding rather than subtracting things, the better it's going to go psychologically for the person. And it's going to take fewer of their spoons and be more fun and joyful, which is what food should be, right?
Yeah, I love that's such a beautiful approach to focus on adding instead of subtracting. I love that. I feel like that line's gonna live in my brain forever.
Yay. Yeah, I think if anything, you know, especially in primary care, like focus on that 30 different plants. You're going to give advice and you have no time to really get into it. That's where I would go, and adding things in, like, can you add in these low histamine foods instead of saying, please avoid these things? Or can you add in more protein? You know, if you're going to talk about macronutrients, often in this population, we definitely need more protein. There's plenty of studies showing that's beneficial to folks, especially like EDS or inflammatory conditions, right? We have loads of stuff on IBD, or any arthritic condition where we just have inflammation going on. Your body needs more protein to manage that situation, right?
Yeah, I'm in like perimenopause, and the amount of protein I'm supposed to eat is like feels dumb.
Yeah, what? Same here.
Excuse me, I'm sorry. I have primarily existed off of cookies and salad for a lot of my life. So
I have a protein cookie recipe. We need it.
Confused with this. Amazing. Well, for our listeners and our referring clinicians, like who are the patients you really think would benefit? I know you're going to say like everyone, but for our referring clinicians, who would you really encourage them to consider? Well, before we even go there, I think that one of the points we made earlier is like trans patients, gender diverse patients are more likely to experience some of these Venn diagram conditions, right? Like more likely to have disordered eating, more likely to have health conditions that like make food complicated, like RFID or sensory processing issues from neurodivergence. Yeah. And then, yes, our little like pentad of like MCAS, hypermobility, connective tissue disorders, and POTS. And
then throw perimenopause in there.
So the precursor to like who would we refer, which newsflash, it's going to be all of those people, but is are you inquiring after these things with your patients? Like, do you know if your patients have these things, right? Because if you don't know, and maybe your patient doesn't know. I was like on like a chat or a Reddit thread where people were like, yeah, I guess this is just my body now. And it was all like perimenopause and menopause symptoms, right? And it's like, oh, yes, maybe, but also maybe there is some things that could make that experience different for us. But if we don't know, like, right, if we don't know and our clinicians aren't screening us for it, like we might not ever find resources around it. So I guess all that to say, clinicians, make sure you're screening. And then Mel, who benefits most from referrals?
Oh, gosh, can I piggyback off of that?
Of course.
Up a minute. Yeah, like besides the protein piece, I think like a couple of other tidbits that could be really useful for people is magnesium and zinc. Just about anybody can get more of that, and those can be very helpful for all of those conditions we just listed. So on the protein piece, like making sure we're getting some more of those minerals. Calcium for perimenopause as well is huge. And oftentimes people have already given up milk at that point. So trying to figure out ways to get that into people's diets as well, I think are really big pieces of that. I'm a big fan of pumpkin seeds and hemp seeds. If you want to just throw some actual like additional things you can just throw at people, like maybe you should have more pumpkin seeds, maybe you should add more hemp seeds because they're just so nutrient dense and full of protein and all of those minerals, besides the calcium piece. But yeah, so who to refer? Exactly. Those patients are kind of my special interest. Patients with the cluster, neurodivergent folks, queer folks, trans folks. If you were to refer them towards my practice, but also definitely screening for those things. I think also just like the muscle loss that occurs in those conditions. I do use the SCOFF to screen as well. Like you mentioned, screening for disordered eating. I think that gets missed a lot. SCOFF is pretty easy. I threw that into my form. It's like 6 questions-ish. So things you can add if you have control over your intake paperwork along the way to make sure that you're catching those patients. But as far as referring goes, I would also not get discouraged if people don't complete the referrals. There was a study I came across when I was deciding on, how to build my practice, that in diabetic patients, only about 25% of those who would benefit from nutrition were getting referred, and then like only 50% actually completed the referral. And so if you are going to make a referral to a dietitian, really giving the patient some background information on why that might also be helpful for them besides weight, because that's the first thing that comes to just about everybody's mind, the patient and often providers. But if you can come at it from a non-weight perspective, from we want to help you feel better in your body, nourish your body, a dietitian might be helpful for that. They probably are going to, I don't have any data for this, but I would suspect they're going to follow up and actually complete that referral much better in my clinical experience. That's what I've seen. But also don't be discouraged if they don't complete the referral the first time. I seem to be completing more of the referrals than that. I think I haven't actually calculated, but it seems to be somewhere in like the 70 to 80% range that I actually am able to get patients scheduled with me that I get referrals for. So I think I'm doing pretty good in that way.
Amazing. And for our listeners, Mel's practice is available remotely in New Mexico, Oregon, Washington, New York, Virginia, and Arizona. Yes?
Yes.
Yeah. And I think Mel's point earlier for clinicians, make sure to, when you're referring patients, like either have vetted the dietitian you're referring to, so you're referring to someone who has the like cultural humility needed to work with that patient, or if like you haven't done that, or you haven't had a student do that for you, or I always be really transparent with my patients about like, oh, I don't know this clinician, I don't know this provider, I can't guarantee like their ability to work with trans community. And so I want you to be like specifically prepared when you go into there versus, oh, I've worked with this clinician, they're going to do great with pronouns, they have like an intersectional approach. you know, or I know this clinician, they're going to do great with a trans piece, but they might fall down on some of the other intersectional pieces, right? Like I try to really preview where I'm sending people before I send them, because I think that's part of like trauma informed care.
Yeah.
Yeah. Okay, amazing. So, and then we didn't even talk about like just like basic kind of nutrition. Well, okay, before I jump into that, I do also want to like highlight some of the things Mel said to like referring clinicians, right? Is like, don't make it about size, don't make it about weight loss. Really make it about nourishing people in their bodies and feeling better in their bodies, and don't make it about restricting things, make it about adding things. And I think those are really, really important, useful, like pieces of information for referring clinicians to have that they can like take action on easily and immediately. And then like we spent a lot of time talking about all of the Venn diagram of conditions that occur more commonly in trans folks, but also just like nutritional needs during medical transition. Like, do you have like a few minutes to like share any insights or wisdom in that component?
Yeah. Yeah, I'm sorry. We should circle back to that. So we don't know much. I think I said that, and we do know like there's shifts in muscle and fat, like that you mentioned. So helping people feel more comfortable in whichever way they want to shift that. Obviously not making assumptions about how they want that to shift. But also around surgery, you know, you do need some more energy and protein around surgeries. You know, my poor spouse lost so much muscle mass, like going through that 6 weeks where you have to walk around like a T-Rex, you know. And really, studies do show, and when your body's going through a trauma like that, we do need to be increasing our protein to support that. Sometimes maybe a little bit of extra vitamin C to support wound healing can be also really helpful. But we don't want to be doing that long term. There's other things that can backfire, and we're going overboard with vitamin C, right? There was a study I ran into recently as a side note about like mitochondria and that decreasing if you overdo it with vitamin C. So if anybody's out there doing a lot of that around the winter season, I would definitely suggest against that on a regular. Or kidney stones can also increase with vitamin C in excess. But trying to like really hone in the nutrients, I think could be really helpful for trans patients going through different types of surgeries as well.
Yeah. And I get asked, yes. And if anyone doesn't know the T-Rex thing that Mel is talking about, it's some surgeons who do, I'm assuming this is, you can tell me if I'm assuming it incorrectly, you know, top surgery for chest flattening with mastectomy or chest contouring, right? Because terminology, but recommend no arms above the head for 6 to 8 weeks to reduce like the stretch tension or widening of the scars. Is the approach. Not all of them have this recommendation. Some of them say it's fine and some of them don't. I'm assuming that's what you were referencing.
Exactly. Yep. Yeah. There was a lot of not moving the arms, and then just like the concern of moving them even after that point, you know, so much care around our arms and chest and moving.
Absolutely. And obviously like, prepping, like nutrition needs prepping for any kind of surgeries, which are like big stressors on our body. Right. And so like nutrition work leading into something like that. So our body's kind of as resourced as possible going through it. And we have a like meal plan for afterwards, you know, like really beneficial for people if that's something that we can access and recommend and refer for. And then I get I'm gonna throw like I did not prep Mel for this question. So if you're like, I just cut this question out of the interview, we absolutely can. I think one of the things I get asked about to some degree of frequency in gender affirming care for my patients is like weight cycling to increase fat redistribution. And I'm so curious if you have run into this within our community, or if you have any thoughts or ideas, although I did not give you a prep time, so I'm sorry.
Yeah, I'm like, I haven't seen anything on that. I have, because we were talking about doing a presentation, I have been like pulling as much research as I can find, and I haven't seen that yet. Have you seen studies on that yet?
No, absolutely not. No studies that I've seen. It's more, and like all of the kind of knowledge I have about weight cycling comes out of like bodybuilding community and culture.
Yeah. I mean, I think my gut reaction to it is coming from like a Hayes perspective, but I mean, yeah, it's definitely used in bodybuilding a bunch. I'm definitely not on like the fitness, I would say, end, although I have cycles where I get, more interested in it. And I think I might be starting a cycle of being more interested in it because it plays also into the cluster, because a lot of the things that are beneficial for bodybuilders are also beneficial for our patients with the cluster. Like creatine has really revolutionized my life and my energy levels. And so that's something I'll recommend for people. So I kind of like circled back there. So trying to put that together, but weight cycling and the studies, if we're doing a lot of like gaining and losing weight, that tends to increase poor outcomes and mortality rates. And that is what is in the literature as far as that goes. So I wouldn't say no to somebody if that was really their desire. I would definitely do a deeper dive before, casting a no, this is like not going to be safe on somebody.
Right. I always tell people when we're thinking like, right, when my patients who ask me about this, I say like, there's no research or literature on it. And there is some risk of harm if we're talking about gaining and losing, significant amounts of weight in a repetitive cycle, like, right, like referencing like literature on weight loss and yo-yo
dieting.
Yeah. And increased inflammation and morbidity and mortality. So I told them like, you have to keep all of these things in mind, but there is potentially some like endocrinologic, physiologic theory behind it that kind of makes sense, that people might see, more change in their weight distribution if they are putting that weight on, losing that weight under the influence of the hormonal milieu that they want and need to support their gender.
Mm-hmm.
And so, but it's not proven, it's just theory. And then if we're going to do it, I'm talking about like, 3 to 5 pounds over a few months, and cycling like a few times, and that's it. Right. So I'm not talking about this like long-term weight cycling plan that like is with you for the rest of your life. And I'm not talking about really large amounts of weight either. Right. But it's like a
very small increments.
Small increments in part to like try to help reduce that risk of like an inflammatory response and worsening outcomes.
Making the metabolism freak out.
Right. So, but I always tell people like, it's like, we don't know. But yeah, like, we'll have you, yes, let's have you deeper dive it and then like come back and we'll talk about it more.
I'm intrigued. I think my other suggestion on that is if somebody is trying to do that working with a dietitian would make it possibly safer.
Yeah.
Because then you have somebody also looking for disordered eating in that pattern and being a second pair of eyes.
Yes, absolutely. Well, I feel like we've just started a whole new referral chain to you. Amazing. Well, so everyone, we will wrap up today, but you can find Mel at morespoonsnutrition.com, I believe. Yep. Mm-hmm.
Yep.
And then we'll put the links to Mel's website And then Sabrina String's work and the Decolonizing Wellness work that you mentioned. And the other book I was thinking of when we were talking about Sabrina String's work, and I couldn't remember, is Belly of the Beast. Yeah, The Politics of Anti-Fatness and as Anti-Blackness by Deshawn Harrison, who is a Black and trans author, is also a really good read. I feel like the other one I think about a lot of times too, clinicians, like just to hear, to build our cultural humility, right? I think it's so important to hear the experiences of people with different lived experiences than us. And I find the Maintenance Phase podcast is very educational in the context of navigating the world in a fat body. And so I pop in and listen to that one as well. Do you have any other like things we should link for people or resources you want to like resource share with our providers before we wrap up?
Definitely the Association for Size, Diversity, and Health. Absolutely. They have several different layers of the Hayes principles, but the most recent one is fabulous. It's very much framed in providing equality for people in different bodies and minorities, marginalized communities, going against oppression in the healthcare sphere, and overcoming anti-fat bias. So I would definitely look at their materials. They have lots of webinars that you can join and just get the 101 at least level of Hayes.
Amazing. Are there any like podcasts you like or any other resources you would like drop?
The FedUp Collective as well.
Are they still? I thought maybe they had phased out.
Yeah, I think they just changed their website. They seem to be still active.
Okay.
They don't have a ton of resources, but they do host some trainings, is my understanding, but I'm not like super tight in there. And then like resources, there's St. Louis University has some like trans nutrition like handouts if you need something just really quick. You can download those in PDF form and print them off for people. Yeah.
Amazing. Okay, thank you for all of these resources. Is there anything else you want to say to our listeners before we say goodbye?
Oh, thank you so much for having me. And if anybody has any questions, they're welcome to reach out to me. I have all my information on my website and like a messaging link and stuff.
Lovely. Thank you so much, Mel.
Thank you. Thank you. It's so nice to